We're in the home of Dr. and Mrs. Paul Bucy in Tryon, North Carolina. As you all know, Dr. Bucy is a real pioneer in American neurosurgery. He's been present at the birth of most of our institutions, which have amounted to something in the world. He's been the professor and chairman at all three of the Chicago medical schools, was intimately associated with Dr. Heinrich Clüver and with Dr. Percival Bailey. It's a delight to be here. Paul and I are old friends. He's been a role model for me for many years. I almost trained with him and would have had I not been enchanted with the city of New York as opposed to the city of Chicago. Paul, tell us about the early days of neurosurgery in Chicago.
I came to Chicago immediately after my internship at the Ford Hospital in Detroit. That was in 1928. I was Percival Bailey's first resident. But when I arrived in Chicago, Percival Bailey was desperately ill with mumps encephalitis and was not expected to live.
Well, that gets it off the ground well, doesn't it?
Accordingly, as the only other member of the department, I took over neurosurgery. I performed my first neurosurgical operation at the request of the neurologist, Roy Grinker, and the head of general surgery, Dallas Phemister, in October of 1928. They had a patient they thought had a brain tumor, and although I had never operated on my own before, I had learned how to open a skull from the neurosurgeon at the Ford Hospital. He was a slow operator, and the other residents and interns at the Ford Hospital did not like to assist him because it took too long. So I took over and assisted him on most of his operations during that time. We had to spend a month in pathology, and while there, the head of pathology asked me to classify the 50 brain tumors they had collected at the Ford Hospital over the years. So I did that. At the end of the month, I wasn't through, and my next month was supposed to be spent on obstetrics. I had no interest in obstetrics, and so I went to the authorities and asked them to relieve me from that responsibility. They said they'd be glad to, but the state of Michigan wouldn't. I had to be present at 15 deliveries. So they arranged that whenever there was a delivery, I would be called from pathology to go over and be present at the delivery, and then I'd go back and work in pathology. So with that experience, I arrived in Chicago and operated upon this patient with a brain tumor. When I got the skull opened and exposed the brain, as was all too common in those days, there wasn't a tumor that we could see. And therefore, perhaps fortunately, there was nothing for me to remove. And I closed up the wound. Later, when the patient died, examination of the brain proved that he had a deep-seated glioma, which I couldn't have removed anyway. From that time on, I continued to operate, doing craniotomies and laminectomies, until Bailey had recovered and was back on the job at the end of November. I remained then at the University of Chicago, but the following February, the head of surgery came to me and asked me if I would like to go to Europe. And of course I said sure. So the university gave me a year's leave of absence, 1930 to 31, which I spent in Europe, most of the time at the National Hospital in London at Queen Square, where I learned neurology under Gordon Holmes. Well, Sir Gordon was by all odds the best teacher at the National Hospital, but he didn't teach with lectures or anything resembling lectures. He taught you by his own examinations and his diagnosis. You had to learn by watching him. There were other very capable men at the National Hospital. Perhaps the most outstanding was Kinnear Wilson, who was also a brilliant neurologist, but more experimentally minded than Holmes, and who had done considerable work on the basal ganglia, and who had studied in Germany. While I was in London, I met a man who has since become very famous, and that's MacDonald Critchley.
Yes.
I was planning on going to the continent, and Critchley told me that, amongst other things, I must stop and spend some time with Schuster in Berlin. Schuster had a large clinic for chronic neurological diseases at the Hufeland Hospital in Berlin. I would go there every morning. He and his residents and other students who were there, he would demonstrate different types of neurological disease. He wouldn't show one patient, but because of the large number of patients which he had, he would have 5 to 10 patients to illustrate practically any disease that you might think of. After we had spent a month with him in Berlin, we went to Breslau, over in eastern Germany.
To see Professor Foerster.
To Ottfried Foerster, where I spent 2 months. Ottfried Foerster was a most remarkable person. He was not a surgeon, although he did surgery. He was originally a neurologist, and during World War I, he had done neurology with the German army. There was no neurosurgeon at that time in the German army, and so Foerster began operating on these patients that required operations by himself. And when he returned to Breslau, he continued to do that. It's unbelievable the circumstances under which he worked. In the first place, he was a crude surgeon. If he wanted to do a craniotomy, he would do the same thing that the English did at that time. He would make a trephine opening in the skull and then take a rongeur and bite out the hole big enough for him to operate through.
Wow.
Throwing the pieces of bone over his shoulder. His only illumination at his operations was a student lamp, one of these brass hemispheres, which somebody had to hold, and everybody tried to avoid being first in the operating room because the first person got designated to hold the lamp.
I'd remind our audience that there's a marvelous picture of Dr. Bucy and Dr. Foerster with that student lamp, which has been published, I think, in Surgical Neurology.
That's right. And I got that picture from Henry Schwartz. Now, where Henry got it, I have no idea.
Well, that's probably true. I wouldn't know either. May I turn the subject a little bit back to Chicago and the early days there, particularly your relationship with Dr. Clüver?
Heinrich Clüver had taken this drug, mescaline, from the cactus plant and taken it himself and produced hallucinations in himself, which he recorded in a book. But he'd also given this to monkeys. And the monkeys who had the drug seemed to have paresthesias of their lips. They would pick at them, chew them, bite them with their teeth. And so Heinrich came to me and he said, let's find out where in the brain this drug is producing this effect. And so I agreed to participate in this study. And first we cut the fifth nerve bilaterally to make the mouth anesthetic. That didn't make any difference. They went on picking their lips. Then we cut the seventh nerve because there was some indication that the seventh nerve contained some sensory nerves from the face, but this didn't make any difference either. And so then I recalled that people with temporal lobe epilepsy sometimes develop movements of their mouth. And so we decided to remove the hippocampus and the medial part of the temporal lobe. In order to do that, it was simplest just to take out the whole temporal lobe. So our first monkey was fortunate. Heinrich had a way with monkeys, and he had a monkey that had been in the Department of Anatomy that became too mean for the other people to handle, but not too mean for Heinrich. And this monkey that was really very vicious and very mean, I removed the left temporal lobe. The next morning early, my telephone rang, and here was Heinrich on the other end saying, "Paul, what did you do to my monkey?" I said, "Why?" He says, "She's tame."
Really?
And so we then proceeded to remove the other temporal lobe. We did that in other monkeys as well, and out of that grew what has come to be known as the Clüver-Bucy syndrome. So that I had a close friendship and association with Clüver and a great respect for him. That man had more knowledge than most people and was a very able person and a delight to work with.
He must have been. Tell me about Percival Bailey.
Percival Bailey came to Chicago, and he hadn't had much surgical experience. As a matter of fact, Harvey Cushing had said to him personally, "I don't know what's going to become of you out there in Chicago. You're no surgeon." And Max Pete up at the University of Michigan made a similar remark and said, "Bailey's no surgeon, he's a pathologist." Well, both of those statements were true. But Bailey turned out to be an excellent surgeon. But he didn't like surgery, which was fortunate for me, because he turned all the surgery he could over to me and did as little of it as possible himself. When Bailey had gone to Chicago, to the university, he had visions of developing a neurological institute, not only neurosurgery, but neurology, pathology, chemistry, psychology, psychiatry, the whole works. And the Rockefeller Foundation had offered the University of Chicago $2 million to develop such an institute, providing they would make Percival Bailey head of it. And the university turned it down. So the institute was therefore built in Montreal with Wilder Penfield.
Wilder Penfield, yes.
Of course, this soured Bailey on things at the University of Chicago. And finally he resigned and left and went over to the University of Illinois. In 1939, when he left, the university asked me if I would become head of the department. And I agreed, but I told the president at that time that I would only take it if they showed a greater interest in neurology than they had up till then. They said they would. I told them I'd give them 2 years to show some signs of interest, but at the end of 2 years, there were no signs of interest, and I too resigned and left. Now, there was another reason for my leaving the University of Chicago. At that time, we had 2 boys. They were still quite young, but I could see that we had their education to look forward to, and my salary at the University of Chicago was $7,500 a year, and I didn't see how I was ever going to educate those boys on that salary.
That's right.
So I left Chicago and went over to the University of Illinois, where Bailey had gone ahead of me, and where Eric Goldberg was head of the department. Well, Eric accepted me with open arms and was very helpful. And I was professor of both neurology and neurosurgery at Illinois and taught both subjects. Bailey, on the other hand, did primarily neuropathology at the University of Illinois. It was while I was at Illinois that the opportunity came up. I suppose it was an opportunity, it was a lot of work, to become the secretary of the board. And I was secretary while I was at Illinois. Now, prior to that, I had been on the committee which had decided to create the board and developed it.
I want to ask you about that. Why was the decision made at that time? Was there some pressure from some other organization to
create the
board?
Yes. Boards then, the board in otolaryngology and the board in ophthalmology had existed for a number of years, and others were springing up. The board in general surgery was just being created. The board in obstetrics and gynecology had just been created. So there was the feeling that neurosurgery ought to have its own board too.
Wasn't there some indication that maybe the Board of Surgery would like to have examined us?
Oh, very definitely. And also the Board of Neurology.
That was my next question.
But our committee resisted both of those and decided we needed an independent board. That was a very interesting committee. I'm not sure I can remember all of them, but I can remember most of them. One of the leaders of that was Ernie Sachs from St. Louis. Another was Max Peet. Another one was Gil Horrocks from Boston. Another was Alf Adson from the Mayo Clinic. And ultimately, those people who were on the committee became the first members of the board. In other words, they became self-designated, so to speak.
Well, not the first time that's ever happened in neurosurgery.
No. The first examination was given in 1940. But before that happened, the board had indicated a number of people, all of whom held professorships in one medical school or another, that they would certify without an examination.
There were 50, as I recall.
I don't remember how many, but
50.
there were a number. And I was one of that number. But at the first examination, there were a number of people considerably older than me who resented my having gotten the certificate without the examination.
Yeah. I'll have to confess to you, when I was secretary of the board, I enjoyed reading some of the minutes and some of the letters that were received about that 50, and some of the people who were highly incensed, I think is the proper way of putting it. They really meant some other kind of words about being excluded from that 50.
However, like with most things,
it blew over.
Those die down.
Yeah, it blew over.
Difficult feelings are smoothed over, and I think everyone is now in agreement that the board is functioning well and continues to do so.
Last time I looked, it seemed to be doing well. You were also in on the formation of what's now the American Association of Neurological Surgeons. It was then founded as the Harvey Cushing Society. Was that in fact formed because people were not taken into the Society of Neurological Surgeons?
Very definitely. The Society of Neurological Surgeons at that time was a very restricted club. It was almost impossible to become a member unless you had been trained by one of the members. In other words, outsiders were not included.
Not welcomed, anyway.
And there were a number of people that felt excluded and were excluded. Amongst those, one was Van Wagenen from Rochester, New York.
Yes.
Another was Glenn Sperling from Louisville. Another was Pappy Sams from Memphis. These people were not acceptable to the society and therefore decided to form their own organization. And we went to Boston, met with Harvey Cushing, and he agreed to allow us to use his name as the name of the society. At that time, we had several people who were taking in who were not neurosurgeons. One was John Fulton. Another was the X-ray man in Philadelphia.
Yeah.
Chamberlain, wasn't it?
Chamberlain, yes.
And there were not a large number, but there were several of these. Most of them were neurosurgeons, however.
I have to interject a personal note here. The first meeting of the Cushing Society I ever attended was as a guest of Dr. Paul Bucy, and the chairman was Dr. Chamberlain.
Oh, really?
That was in Hollywood Beach, California, and he was the president that year.
Well, I'm glad to be reminded I did something worthwhile, but I had forgotten.
Tell me, how many residents have you trained in neurological surgery?
About 60. I have recently written a letter to each one of them, telling them that I hadn't heard from them in a long time, and I would like to. I've had several replies since, and there are more to come. But there are a number of former residents who have become quite distinguished. Among these is Fabian Isamat in Barcelona,
Very much
who is
so.
the president of the European
Yes.
Federation of Neurosurgery, and was president of their Congress recently held in Barcelona, which I think you attended.
Yes, I did.
He is one of the residents of whom I am very proud. Another one is Pat Kelly, who has developed stereotactic surgery of brain tumors and is now at the Mayo Clinic, and seems to be doing very well there and is highly regarded.
He's sort of the stereotactic surgeon at this point in the world, I think.
That's right.
He certainly has the most extensive and expensive apparatus of anybody in the world.
And do you know that when he was in Buffalo, he paid for all that apparatus out of his own pocket? He had no research support?
Pat told me that
Yes.
in a conversation I had with him once about it. And let's see, you of course trained the man who interested me in neurological surgery, Robert Heimberger.
Oh, yes. Were you at Indiana?
Yes, don't you know that story? How
Well, I probably did it one time. I don't now.
it's really sort of interesting. I, of course, had done my internship there. And the then neurosurgeon in Indiana had a falling out with Harry Shoemaker, who was the chief of surgery.
Yes, I remember it.
And Dr. Shoemaker, in his forthright way, after 2 or 3 days of interchange back and forth, discharged this gentleman from the faculty of Indiana. And I got this call to come down to Dr. Shoemaker's office, and of course, as a resident, I thought, you know, Lord, what have I done? You know, do I pack my bags first or second? You know, I went down, and he told me what he had done, that he discharged this neurosurgeon, and that he had just hired a young man finishing his training with Dr. Paul Bucy, and he wanted me to be the resident on neurosurgery to show him around and help him learn his way around the hospital. And I said, fine, I'll be glad to, Dr. Shoemaker. And about 3 or 4 days later, Bob showed up. And of course, we were pretty close of an age, actually, at that time.
Yes.
And we became close friends, and have remained friends all these years, ever since. And I took him around through the hospital and showed him the ropes and introduced him to the patients and helped him with his first independent operation, and, and he got me interested in neurosurgery. I spent 6 months doing that.
Why did you leave there and go to New York?
Again, an interesting, funny kind of a story. I was drafted for the Korean War. And while in the Air Force, I was asked to go to Indiana, to go to Washington, to the Surgeon General's office to do something. I've forgotten what it was. And I was then going on to New York to the College of Surgeons meeting. And it turned out that the guy I ran into in the Surgeon General's office had been my executive officer when I was a hospital commander. And we got to talking, and he asked me what I was going to do, and I told him I was going to get out and go back to Indiana and train in neurological surgery. And he said, "That's where Dr. Robert Heimberger is the chief." And I said, "Yes." He said, "You better think about that again. I just cut orders on Captain Heimberger to go to Germany for 2 years." And I said, "Uh-oh." I don't think I want to go there for 2 years without Bob. And I'd lived in New York before, and I liked the city. And my consultant in neurosurgery in the Air Force had trained at Neuro, and I liked him.
Who?
A fellow named Bill McKinney.
Yes, I know.
You know, and I liked Bill, and I thought he was
In Fort Worth.
In Fort Worth.
Yes.
And I thought he was a pretty good neurosurgeon. So
A nice guy.
Lovely guy. In fact, I saw him in Toronto. I hadn't seen him in years.
I didn't know whether he was still living.
Yes, he's very well. He says he regrets very much retiring. He said, "I'm far too vigorous to have done that when I did it." And so I called for an appointment and went up and saw Larry and talked with him and got the appointment. So how do you see neurosurgery today? I know you've been retired for a while, but you obviously keep up with it. What do you think's moving the field these days?
All sorts of things. I think that the developments in neurosurgery in the past 15 years, or maybe 15 or 20, have been almost beyond belief. There are so many things which have happened. First was the improvement, going way back to Cushing, in the ability to control bleeding with the Bovie and with the gel foam pledgets and with easy blood transfusions, which initially back in the 20s and 30s were a real problem, very difficult.
I think they've become a problem again, but for a different reason.
Yes. And then the next thing, as I see it, which came along, was that we learned from the otologist to use a microscope, which has completely revolutionized neurosurgery. It became possible to do aneurysms much better than we were doing them, to preserve nerves, to preserve small blood vessels, because we could see them. And then the next thing happened with the English electrical engineer who invented the CT scan. Now we didn't have to rely anymore upon ventriculography, which was dangerous and not always satisfactory. And now comes magnetic resonance, which is even better, so that the advances have been great. There have been other changes which occurred, which you're in better position to evaluate than I am. For instance, in the treatment of herniated discs, are these intradiscal procedures a real advance in that area?
Not really, and of course, as you perhaps know, most of them have really been abandoned because of, one, the instance of complications, the lawsuits against the manufacturers, and the fact that there's no more gratifying patient than the person who has a herniated disc and has a good operation for it.
I always felt this way. We reviewed our patients that we had operated upon, my associate, Dr. Oberhill, and I, and found that 95% of the patients we'd operated on were very happy with their results. Not all of them were completely relieved of symptoms. Over 50% were, but not all of them. But even those who still had some symptoms said, these are so minor that they don't amount to anything compared with my original trouble.
Right.
So I never could see any reason to change my operative technique from what it had been.
I think that most people came to the same conclusion. I remember one of my former residents and colleagues, Clark Watts, looked at a comparison between interdiscal surgery, interdiscal injection,
Yeah.
and open surgery, and showed that there really was no difference in terms of cost, risk, outcome, one thing or another, and that the surgery was really better tolerated than many people. I know my only experience with it was with Clark, and
Great guy.
thank you. I think so too.
Oh, yes.
And I remember he injected a patient of mine, and I sent him for this, and that poor guy lay in the hospital for about a week with the worst back pain you ever saw from that injection. What about, what's your feeling about the numbers? We hear this all the time about how many people we're training in neurosurgery.
I don't think we're training too many. If you look at the figures, the number of people who are going to die and who are going to retire, we're barely training enough people to take their places. I don't see any risk that we're going to have too many.
Do you think that, as our population ages, if you think of the median age of the American people, they're now in a age group where their predominant neurosurgical diseases are trauma. But in another 10 or 15 years, they'll be moving into the group where the brain tumors and the aneurysms and the one thing and another. The median age of the population will catch up to us. And I think we'll need more rather than fewer.
I do too. But we are not training any more than enough to fill the vacancies.
Yes.
Now, there are still places that don't have enough. They're not as numerous as they once were. There was a time when there was no neurosurgeon, for instance, in the entire state of South Dakota. Well, there are, 3 or 4 there now?
About 5 now there. Yes.
But there are still spots in which the patient cannot get to the care of a neurosurgeon with the readiness that he should be able to. And there are neurosurgical conditions. Trauma is the outstanding one, or an acute subdural or extradural hematoma that requires immediate treatment. And there's no neurosurgeon available within miles to do that. So I think we are in need of more neurosurgeons than we're training.
I think we'll end on that note. Thank you very much, Dr. Bucy. It's always a pleasure.